speaking now. But basically, just as well for chem tutoring as it does for moral development. What you don't want to do is this concept of over-justification, where you do the Freud and you punish or even you reinforce too much, because then it can become a matter of then things become a matter of how do I get the punishment, or how do I avoid, or how do I get the reinforcement, or how do I avoid the punishment, as opposed to why am I being rewarded or punished in this way. So again, it's something you intuitively know. You don't want to spoil the kid. You don't want to traumatize the kid. You want to go so you want the golden mean in Aristotelian terms. We do know that not every child internalizes values in the same way, though. It's not, you know, different amounts of motivation are needed to inculcate the same ideas. If that weren't true, we'd probably have a lot of brothers and sisters that were very similar to each other in terms of moral opinions. But we know that's just from life that that's not true. So there must be something a little bit deeper than just there's a one-size-fits-all moral development formula. So our next big theory, so we talked about Freud and why he was wrong. Next theory comes from that Jean Piaget guy we were talking about earlier. So he was the guy with the four operational stages of child development. He also has a moral component to his philosophy. And basically, the same way that he focused on fundamental shifts, processes of equilibria, right? Or equilibration. The same way that he's focusing on fundamental shifts between stages before cognitive development, he's focusing on 3 critical changes in moral thinking that lead to new stages of moral development. So your first shift is, and these are all very abstract terms, so if I'm not explaining them well, please stop me. But our first shift is this idea of realism to relativism. So again, we're talking about moral values. Here, right, the assumption is that the kid first thinks about social laws as something as immutable as physical laws. They're real. They're a part of the real world. They're not something that can be changed easily. It's just a fact that things fall, and it's just a fact that people who embezzle money go to jail. Those are equally deterministic outcomes to the young child. So Piaget says you reach this shift where you go from realism, where everything is just part of the natural world, right? It is against some kind of, universal law to hit people, to saying relativism, rules are human inventions, and there are times in which rules must be excused for an extenuating circumstance. So the classic intro philosophy example is murder in self-defense is acceptable in most cases. So we go from a position where things fall and people who hit get punished are equally true to people who hit only get punished when the human rules make them. So it's a shift away from thinking of moral rules as physical rules like gravity or electrostatic repulsion, right? Next up, prescriptions to principles. So prescriptions like the doctor stuff. Prescriptions to principles. Again, you'll notice shades of Piaget's earlier work where there was a focus on the concrete here and now infant shifting to an adult that can handle abstract ideas. And you see here especially something very much in that regard. So this happens after the relativist shift. And basically the child stops thinking about rules as they pertain to specific actions and instead starts thinking about rules as implementations of some broader principle. So at first, don't hit might be limited to, okay, well, apparently things don't go well when I hit my brother. Things don't go well when I hit my parents. Things don't go well when I hit my school children. But things do kind of go well when I hit my school children and no one's looking. Right? So the idea here is that every moral rule is a specific prescription for a specific act. It's not that hitting is wrong, it's hitting my brother was wrong. That's a prescription, right? And you can imagine you'd have to write a prescription for every possible shade of an action. The principle is a more abstract, broad idea that striking somebody is bad, whether or not you get caught, whether or not it's someone you've hit in the past and found out that's not good. So again, you can see that concrete to abstract shift that really identifies Piaget thinking. Third and last is this outcomes to intentions. So what does that mean? Outcomes to intentions basically means that when you're evaluating moral worth, are you concerned with what happens as a result of an action, or what thought went into that? So an example, you are walking in the hallway and you run into someone and cause them to drop their science project. Are you as bad as somebody who went into the hallway, made eye contact with the kid carrying the science project, and charged at them? Well, if you have a purely outcomes focus, you would be, because in both cases, the negative idea of forcing somebody's science project to break when you didn't benefit at all plays a role, right? So that's a very outcome-focused way to think about the world. When you shift to intentions, you can think more along the lines of, okay, well, the person wearing the linebacker outfit making eye contact with the kid, probably not doing the right thing. But the person who just inadvertently bumped into the science project, not nearly as bad. Again, you can think of outcomes as being what the kid can directly observe. Intentions wait upon this attending theory of mind and ability to empathize with other people, and these are all things that take time. So that is Piaget. Next up is a very similar style of developmental theory, the Kohlberg theory. Like Kohl's like the department store, Kohl, and then Berg, Kohlberg. So this one is pretty Piaget-ish. You'll notice some small differences in between the lines, but there's 3 levels or stages. So you have the pre-conventional stage. Okay. The conventional stage, right? I'm just going to put con here. And then the post-conventional stage. Go figure. Okay, that's kind of easy. So leave yourself some space. As always, we'll go through what those are. Level 1, the pre-conventional level. I don't think you need to know ages, but I'll tell them so you have context. 7 to 10, roughly, this pre-conventional stage. And here, your goal in following moral principles is directly to maximize your pleasure and minimize your pain. So hitting someone behind the dumpster at preschool, or I guess at grade school because it's 7 to 10, not as big of a deal because it's not going to impact you, your experience, your punishment, your reward. Selflessly volunteering for a day, if it makes everyone, make you feel good, right? Give you some of that sweet, sweet vindication, then you'll do it for that reason. But you won't do it because volunteering is good. You'll do it because it's good press for you. So basically, you can think of level 1 of Kohlberg as the selfish stage, I guess, where you're trying to obey for the sake of making your lot in life as good as possible. You're very individualistic. Level 2 is, I'll give you some time. I recognize that was fast. Level 2 is your conventional stage. Okay, so this is like 10 to 16, adolescence. So now you're actually internalizing what you were taught. All those lessons you learned that, resulted in punishment if you did that. You're starting to internalize that maybe hitting people is bad, just like bad. Um, this is where Kohlberg would say a conscience comes in. So, especially towards like the middle and end of this, you start having an idea of I should/shouldn't do this because this is right/wrong. And that's novel because in the past it's I should/shouldn't do this because it makes my life better/worse. But Kohlberg's making an argument here that around adolescence you gain this ability. So you're still only internalizing things that you're taught, and that's a key difference to the post-conventional stage that we'll get to. Basically, you can weed out the individual morsels of like the lessons that you've learned. You can draw from that a broader conclusion of what is right and wrong. But if you're presented with a new situation that doesn't really fit neatly with what you were presented before, you wouldn't be able to do that until your post-conventional stage, level 3. This is anything above 16 for the most part. And here you have abstract principles that can be applied to new areas of morality. So if you just learned your moral lessons from hitting people, right? Now all of a sudden you have this broader idea of violence is bad, and you can apply that to war, even though you don't have any experience of being rewarded or punished for war, right? Maybe you have the idea now that you apply this abstract principle of no hit to war in general, and senseless human-on-human suffering is bad. This is the post-conventional stage. You're beyond just thinking about the conventions you've learned. You're really thinking that there's broader principles at play. So it's very Piaget in the way that it works. What we find in both of these thinkers is that they don't think that most people graduate all the way. It's actually kind of interesting. Like Piaget especially believes that some people never get past prescriptions to principles, and they never really internalize any abstract thought. I guess it's a profoundly misanthropic way of thinking about morality, but almost seems to be justified sometimes. Another little bit about moral psychology, not as a statement of value, as a statement of fact. There's my disclaimer. Men tend to think about, or men, the gender men, tend to think about abstract principles more when they think about morality. This is something that there's psychological, of course, psychological evidence, take it with the requisite grain of unreproducibility, but men tend to think more in abstract principles and justice. Women tend to be more attuned to the like social relational idea, more concrete. So the reason we bring this up is that in the past, especially Kohlberg, Kohlberg was a guy, and his theories of moral development were based on tests that he would give out to people. And those tests really encourage this abstract thinking, less so than encourage thinking about relationships. So an example of a relationship in this case would be like inequality in power. So women might be more capable of saying there's something profoundly wrong when, to use a modern example, 1% of the population owns 40% of the wealth, right? That is a social relational term. You have the relationship between the 1 and the 99, and the concrete reality of 40 versus 60% of the wealth. Men might not have such a sticking point with the relationship side of things, but they might say in general that equality is good. That's the argument that's being made. Kohlberg, though, really only tested the latter, so he found that men were way more moral than women. And that was like accepted in psych circles for a very long time. Now, if I said that now, I would understand your negative reactions, but I suppose it's a product of its time. But the actual differences in terms of the abstract versus relational are somewhat reproducible today. One last thing that you talk about is the degree of morality based on a society, right? Are you in a developed or developing society? It's often easy to say that like the barbarians or savages of less developed societies are less moral, that's usually coming from a standpoint of different cultural expectations. Um, there's no evidence that people of like different levels of a geography, so people in Europe versus people in the West Indies, or b culture, have different skills when it comes to mental thinking. It's just that they might have different conceptions of what's right and wrong. So if the Westerner goes into the third world and applies all those beliefs, it might appear like, look at what they let them get away with. But in reality, it's just they have a different philosophy. I don't know why Andre stresses that so much, but he does, so I'll make a point of it. With that, we have a little break in ideas. I'm not going to do the break quite yet because there's some overarching terms I can talk about with the psychopathology. But again, as you know, questions are always welcome. If nothing, I think we can go on to the psychopathology. So I think this is the focus for the rest of your psychopathology, meaning like mental illness, and therapy, I believe, are the focus for the rest of your semester. So before our break, I'll go over the intro, like what is a psychopathogen? Like what exactly are we talking about here? And then we'll get into specifics, and you'll see that the rest of the class is very based on these specifics. Okay. So psychopathology has a big definition that I can give to you. Basic idea is that it's something that alters your ABCs, right? It's a problematic way of feeling, so affective component, um, behavioral component, thinking, cognitive component, right? Um, when we talk about psychopathologies, we're generally thinking of something a little bit worse than, oh, I have such a bad habit. I bite my fingernails. That's not a psychopathology. A psychopathology has to disrupt a general sense of well-being, so it has to make you think about the world in much gloomier terms than you usually would, or much different terms. Um, it has to disrupt your normal everyday life. So, is it ADHD if you don't have trouble focusing at school? Maybe, maybe not, but that's definitely a question that needs to be asked, right? Is it really disrupting your life? And your three big terms must be persistent, harmful, and uncontrollable. Those are the things that I think I would take away from this definition. Persistent, harmful, and uncontrollable. That's why biting your fingernails, even if it's unhealthy, or oh, I'm such a neat freak. I wash my hands 10 times a day, which I guess is not so maladaptive now. But um, to qualify as a psychopathology, a problematic way of doing all these things, you have to hit this bar, and that's not a low bar. Historically, we've always thought, not we, especially Western cultures, and also animist or shamanistic cultures, have thought of mental illness as supernatural possession. Admittedly, some portions of society still do now. But the idea of you need to have the demons or witchcraft expunged out of you before you can return to normal. Obviously, we don't quite do that anymore. The occasional exorcism, I guess, in your Catholic circles is all you'll see. But now we subscribe much more to this modern medical model. So here we're saying, okay, we're going to treat mental diseases somewhat similarly to physical or physiologic diseases. So you can think about, there's a whole bunch of medical terminology that we can talk about here. The way to think about this modern medical model is it's always looking for specific causes. So like a biological cause, you have lesser degrees of synapse formation. Therefore, that's a cause of depression, right? Um, It's always, psychological causes might be you've had this trauma as a kid. Let's see if we can see where that comes from, right? How that affects you. It assigns and defines symptoms. You'll see this a lot with our Diagnostic and Statistical Manual 5 that was coming up. Um, you have symptoms. People who have generalized anxiety disorder, go figure, have the symptom of anxiety. And if you don't have anxiety as a symptom, you're not going to have that underlying disorder. Lays out treatments aimed at cures, getting rid of the causes. So I guess the historical supernatural view wasn't that far off if the cure was just the power of Christ compels you. But that's the idea of this modern medical model. Some terms to know. Whole bunch of D words. First off is a disorder. Disorder is a common set of signs and symptoms. So, this is thinking less about the cause and more about the effects. People with depression might be more socially withdrawn. They might be less motivated, right? They might have less willingness to do new things. That's literally just less motivated, Joey. But you get the point. When you have a disorder, you're thinking more about the signs and the symptoms. When you have a disease, you're thinking about the underlying physical problem at hand. So in this case, the disorder of depression would be all the things I just outlined. The disease of depression might be a lower rate of synapse formation in the brain, or less neuronal activity in the brain. Something physical, even if it has a psychological origin, something physical we can point to and say, there's your disease, there's your problem. Diagnosis is the word you already know. It really means through knowledge. But basically, is a disorder or disease there or not? Diagnosis. Go figure. A term that is on your test and you won't want to confuse with that is a prognosis. And a prognosis is a forecast of how a disease will progress over time. So, to use a relevant modern example, if you go to the ER for COVID-19 symptoms, you might be told, okay, we're going to give you this medicine, probably not hydroxychloroquine, as it turns out, but we're going to give you this medicine, right? You can go home, you'll be fine. We don't project the disease to be so bad. Or they might say, we project the disease to be a problem, you need to get to the hospital. Those are prognoses of COVID-19, and you can think of the same thing when we're talking about something like depressive disorder or underlying disease, right? This is something you could deal with on your own that'll go away versus this is something that's going to keep getting worse and worse and worse until you deal with it. Two very different prognoses. I made passing mention of your DSM-5, your Diagnostic and Statistical Manual. This is a 3,000-page copyrighted book that psychologists get from membership in the APA. And basically, it says, here are all the known symptoms, or here are all the known disorders, here are all the known diseases. You, the psychologist, can use this book to diagnose people, right? Diagnose people with diseases if they fit a certain number of criteria. So, for example, the ADHD reference will have criteria like easily distractible, doesn't focus well at school, intensely interested in niche topics, right? And if you check enough boxes on the way down, congrats, you can diagnose someone with the disease that you're thinking of. So it's important to remember, A, that's what's actually going on here, but B, that's how you get diagnosed with something when you go to a psychologist or psychiatrist. And it can also tell you about the severity, right? How many boxes do you check and how severe are the boxes that you check? It tells you a lot about a disease's prognosis. All right, we're almost there. Another medical term to know is this idea of a comorbidity. You know what the word morbid means, right? It's like overly dark or problematic, depressing almost, death-focused. A comorbidity means that you have something problematic occurring alongside, with something else. So two mental illnesses might come together in a package, or just two mental conditions might come together in a package, but usually you're thinking about comorbidity with disorders. So an example of this, I'm trying to think. We'll get there. You get the idea of a comorbidity, right? I think it's intuitive enough. All right, we're getting there. Few other terms. A term that's like related to this modern medical model. We're talking about the underlying diseases. We use what's known as the this is a mouthful, biopsychosocial model of causality. So this is a big word that's scary, but if you think about it, it's really not. The biopsychosocial model is trying to figure out what's the cause, what's the underlying cause, right? The causality of disease. Why are we here? And you could have bio factors, right? So chemical abnormalities in your brain, poor genetics. You could have psychological factors, patterns of interpersonal interaction or past trauma. You could have what are known as environmental factors or social. Remember, social and environment. Social doesn't always refer to interact with other people in psychology. It can also refer to interacting with the broader environment. And here, we would be talking about things like, did you have a rough childhood, didn't grow up well? What kind of stressors do you have in your life? Are you discriminated against categorically by the society in which you live? And basically, we're saying these are the triggers that lead to a disease. An alternative to this that's very closely related is the diathesis stress model. So the diathesis stress model is kind of similar, but it says that you can't really have one without the other. So biopsychosocial might say depression is the outcome of lower synapse formation and purely biologize. The diathesis stress model focuses on the effect of what's a stressor, so something from the outside world, right? Something coming into you. A stressor in triggering a latent genetic predisposition. Diathesis, the big word for genetic predisposition. So here we're saying you need both of these guys to mess you up to get a disease. Certain populations, actually including Irish people, have somewhat of a genetic predisposition to alcoholism. But that doesn't mean that they're all helpless. It's much more likely that alcoholism would only start when you have a significant stress, like a divorce or losing your job or something like that. Again, it's kind of a intuitive way to think about something you already know. All right. We're getting so close. I know I went past my usual break time, but I'll make up the difference. Another term here is the intervention causation fallacy. Intervention causation fallacy. That's a lot of syllables, but it's a really simple idea. Basically, intervention here is referring to a treatment. Causation is referring to the cause of a disease. Go figure. If a certain treatment does something, is the lack of that treatment the cause of the disease? So the example that you probably heard in class was if selective serotonin reuptake inhibitors fix depression, or at least help deal with it, is a lack of serotonin in the synapse responsible for depression? No. We now know it's much different from that. But having more serotonin in the synapse happens to help you get through the day. Like it masks the underlying effects. So you can't say just because something worked. Okay, another example, right? I can't dunk, go figure. But if you intervene and give me like a 4-foot stool, I can dunk. Does that mean that the reason I can't dunk is that I don't have a stool? No, the reason I can't dunk is that I'm short. But it gets a lot easier when I have the treatment that kind of compensates for it without solving the underlying problem. If you are aware of any stools that make somebody taller, let me know, but I am not. So in that case, the intervention causation fallacy would hold. I think that's intuitive enough. Last term here is this idea of stigmatization. So, stigmatization. Okay. Well, you know what that is. But basically, do we treat people differently when they're mentally ill? But once we slap a label on someone, do we treat them in a way that's patronizing? Do we treat them in a way that's insulting, that makes further seeking out of treatment less likely? And basically, you have to strike a balance between slapping out labels that say you're worthless, everyone is worthless, right? You have to strike a balance between that and not giving out any diagnoses and doing nothing to solve the underlying problems. So that is a central focus of this modern medical model, is how do we balance stigmatization, slapping a term on it, and the negative effects thereof with the positive effects of this is the underlying rationality behind what's going on in your brain. Okay, it is 9:20. As is tradition, we will start up again around 9:25. I will stick around for a minute or so in case you have questions. But take your 5-minute break now. Do whatever you want. I'm back. Certainly let me know if you have any questions before we get back up, but I'm going to erase everything up here unless you speak now. You'll also have the recording um, in case you need it, but okay. Let's see. Let me get back to where I actually was. Okay. The first general category of these psychopathologies that we're going to talk about is anxiety disorder. So, or anxiety disorders. So, anxiety is it's normal to have a physiological and psychological response to stress. It's normal to have more blood sugar coursing through your veins. It's normal to be really alert and butterflies in your stomach kind of feeling when you're stressed out. But when you start experiencing anxiety and the lack of any real danger, it can become persistent, uncontrolled, and harmful, right? So this is where we talk about the balance between stigmatization and help. We think that when there's no real danger, this becomes a problem. That doesn't mean that if you feel anxiety once or twice, the world is ending. So persistent, excessive anxiety, vastly disproportionate to the cause, is what I would think of. Or there might not be a cause, I guess, reading this. Interestingly, some estimates say about 20% of the American population has these disorders, which seems to say a lot about the way that we live modern life, that we're scarring all these people. But we'll see that those kind of numbers are pretty common with diseases in general, mental diseases. It's scary. First big term to know is generalized anxiety disorder, or GAD. Um, Here we're talking, this is a very general term, hence the term generalized. Kind of your umbrella, any chronic, excessive, and generalized anxiety without a precipitating cause. Chronic, excessive, generalized anxiety without a precipitating cause. It's not that I'm anxious about this test, it's I'm just anxious. I live in a state of anxiety. This is something that I couldn't imagine living with. We know that there's some biological heritability of GAD, but it's hardly hopeless if your parents have it. You'll see that other disorders are more heritable, others are less. Usually, remember our diathesis stress model, right? Heritability implies some biological role being played here. But usually you need a major life change to trigger generalized anxiety disorder. So your most common examples are divorce and losing a job. A common theme that we'll see with these mental disorders that's hard to extricate between people being more willing to seek out treatment versus actual underlying causes is that women get GAD about twice as often as men. Again, that's a really common theme. It's not so much women are so anxious, it's just like it's a common theme with these mental disorders is that women get them more, but it's about a 2-to-1 disparity with GAD. So in general, you can think of GAD as your like umbrella term for living with anxiety. But we also have more specific manifestations of anxiety that get specific terms. The most salient example of which is panic disorder. Panic disorder. Panic disorder. So this is an anxiety disorder, so it's still well within the purview of our header here. But you have a sudden occurrence, so sudden, that's a big thing, sudden occurrence of multiple physiological and psychological symptoms. So the main takeaway here is that both your body and your mind are pointing to being terrified. Terror is a fundamental emotion. Breakdown, feeling overwhelmed. But it's all very sudden onset. Panic disorders are always pathological, but they tend to be most so when there is no environmental cause. Oftentimes they come completely without warning. And you can imagine how debilitating this is. Like, again, this is beyond the occasional cry in the shower. We've all been there. But this is like, I have to stop for a second because I don't know why. There really is no why, but everything is scaring me. And that's, yeah. Perhaps the best testament to how bad this is that of every single psychological disorder, even the nastiest ones we know, the highest proportion of panic disorder victims attempt suicide. So, like, yeah, that's clearly quite a tough life to lead. We think that about 22% of the American population has had a panic attack at some point. But again, usually we're talking about persistent panic attacks before we play this card. Something that we've noticed, a chemical called sodium lactate, and I don't really know why you're learning this. I guess it's a multiple choice test question. But sodium lactate is a chemical that builds up. It builds up in your blood. You've heard of lactic acid fermentation in your blood. So it builds up in your blood as a waste product, especially of anaerobic fermentation. So like when you're weightlifting or when you're really exerting yourself exercise-wise, or it can just be in the present generally. But see, this chemical seems to exert its effects on the brain such that panic disorders come about. Like you put someone with this disorder in a room with an IV, you put in the sodium lactate, and pretty shortly after, a panic attack will likely result. We can also talk about psychological causes beyond just the physiological sodium lactate buildup. A psychological cause is any time you feel like physiological arousal. So maybe you feel on edge, maybe you even just feel hungry. You feel some kind of change in your biological state. You interpret that on a subconscious level in a way that you're not immediately aware of as anxiety and terror. That's a lot less sciencey than here goes sodium lactate, right? And see how that does. But it seems to be a common underlying theme. Just like GAD, women are twice as likely to suffer from this or be diagnosed suffering from this again. Guys, we're tough, right? We're tough. We don't deal with that. I guess that's why. But that's panic disorder. Stop me if you have questions, but if not, and I'll give you a little bit to write, we can move on to phobia disorder. Okay. So phobia disorder. This is another one where it's kind of hard to draw the line between pathological and, oh, you're just scared of spiders. But it's a persistent, excessive, and irrational fear of something that shouldn't give you a fear. So persistent, excessive, irrational worry about something far out of proportion to the danger it presents. Your most common ones would be animals, go figure, spiders. Needles are a really common one. Needles, yeah, they hurt a little bit, but do they really present that much danger? No. Natural environments. Yeah, you can think of really anything as triggering a phobia. A predominant school of thought with phobia disorder is this preparedness theory. Preparedness theory. And this is a very evolutionary way of thinking about it. Basically, they're saying, why don't we have phobias to anything and everything equally? Well, we tend to be scared of things that could, at least in the past, or actually can, present a real danger. Sharp things that make you bleed tend to be problematic in nature. They're not as finely tuned as a syringe. But, you know, you still feel the same reaction because you feel viscerally concerned. Spider venom is a problem. You want to avoid venomous insects. So why be scared of spiders? Way more than you'd be scared of like robin birds or something like that, right? They're not going to kill you. Spiders, I guess, theoretically could. Phobias are a unique example. You don't need to know this term, but of like a self-fulfilling prophecy. So by existing, they make themselves exist harder, which I realize is very shoddy English. But you you have a phobia and you avoid the real encounter with the object of the phobia that could convince you it's not dangerous, right? And because of that, you never really learn how innocuous the object of your phobia actually is. Um, you know, if you picked up a spider, it wouldn't kill you, and you'd realize, okay, well, I shouldn't be trying to run from them like they're going to kill me. But if you have arachnophobia, you're just going to avoid the spider. So naturally, you're never going to get that, reality check. It's not so big a deal. We could talk about a biological cause of the feelings of phobia as imbalances in dopamine and serotonin. That is a phrase you will hear a lot in the next 3 lectures in this class, imbalances of dopamine and serotonin. But that's like the biological cause of this fear response. Our environmental causes, so if you remember environmental, social, this would be conditioning and learning. The biggest example is, do people avoid dogs because they've been bitten in the past? If you didn't have that conditioning experience of dog negative reaction, you probably wouldn't be scared of dogs. Okay. Also now we're getting to terms that are less intuitively under the anxiety disorder umbrella, but they certainly still belong. Next up is obsessive compulsive disorder, better known as OCD, one of the most frequently underestimated disorders that psychologists deal with. Basically, what OCD is, it's the repeated incidents of unwanted, recurrent thoughts. That is the obsession, the O, followed by behaviors done to repress those thoughts, the compulsion, the C. So you consistently feel like you need to check the light switch that's off. You have an obsession like, oh, did I turn it off? It's a thought. The compulsive behavior is walking to the edge of the room and turning the light switch off, right? And even when you do the compulsion, it doesn't really make the obsession go away for any longer than a little bit. So you kind of keep doing the compulsions. Hand washing is another OCD issue. Liking your room to be symmetrical is not an OCD issue. Interestingly, we find that we don't find that 2x, 2 times women to men ratio here. Men get OCD slightly less than women, or they get diagnosed with OCD slightly less than women, but it's certainly not 2 to 1. It might be like a 1.15 to 1, if I had to guess. You don't even know that number. Usually OCD onsets in early adulthood. Again, you could think about, is there some kind of environmental stress that triggers a diathesis? But that tends to be a common theme, is early adulthood is the onset. Our final anxiety disorder is post-traumatic stress. You know what this is. You have a continual re-experiencing of a traumatic event from the past. So basically, you tend to avoid having excessive anxiety about events that are similar to to the traumatic experience you've had in the past. People who have had abusers from their family with a specific set of facial features, if they're abuser from the family that had glasses, they might recoil every time they see glasses. That is an anxious response. So obviously the post-traumatic is what makes PTSD most salient. Here we especially tend to see heightened rates of substance abuse among victims of PTSD. And that's true of Vietnam War veterans who have much higher opioid addiction rates, Again, that's not something you need to know, but it's true. Um, you know, people who have suffered abuse in the family have much higher opioid addiction rates. It's pretty sad, but it almost calls into question the degree of free will that these people have. But that's a conversation for another day. When we talk about all of these anxiety disorders in general, you could talk about your biopsychosocial causes. Obviously, some of them, like, okay, panic disorder in particular, you press the sodium lactate button. That's not something that triggers all of them, but there are some common themes. Anxiety disorders tend to be modestly heritable, kind of like GAD was. So, maybe if a parent has it, the kid has like a 30% chance of getting it. You're not screwed. You're not in a great position either. Anxiety disorders often go together as well. They often are comorbid, which means that they probably have similar underlying biological causes, or there probably is a biological cause common to each one. Psychological causal components tend to be different coping strategies with stress, and differences in the way that you label like physiological arousal. So every time you feel something strongly, do you automatically go down the fear and terror route? Do you feel threatened every time that you feel excited? If you do, you probably have an anxiety disorder. Situational or social, change is the big fact. Change, major life events. You could also talk a little bit about social learning, like you could actually learn these from other people, but generally you will have some kind of big life change. And again, it's usually a tragic one. Sometimes it's a happy one. A lot of lottery winners get these conditions, which is not something you need to know. Not something you talk about in class. People who win the lottery because of the uprooting change in their lives suffer a lot more from these. It's almost like money can't buy happiness. Okay. Next up are the mood disorders. I think I'll be able to get through them today. We'll see. So the mood disorder. So what is a mood? So a mood is a long-lasting, non-specific emotional state. So a specific emotional state would be, I'm angry at you, but I'm not interpreting everything with a tinge of anger. I'm not in an angry mood, but hearing, you talk is making me angry. That would be a specific emotional state. A mood would be everything I do has a tinge of this emotion. I'm in a good mood. I experience everything a little bit more positively than usual, right? And it's longer lasting. Mood can become pathogenic when this like tinge that you feel on top of everything disrupts normal functioning of life. Go figure. So, okay. Our biggest mood disorder and our most common one is major depressive disorder or just major depression. This is generally what you think of when you think of depression. You have a severely depressed mood, which again, depression tends to mean feeling less more than it means feeling sad. You might think of things negatively, but it's almost like you have nothing, no motivation, no. It's kind of scary. Anhedonia is a term that means lack of pleasure taking. You might recognize hedo, words like hedonism or hedonic principle, talking about pleasure and pain. Anhedonia means that you just don't take pleasure at all. In general, to be diagnosed with this, you need to have this severely depressed mood and anhedonic state for 2 weeks straight. So 2 weeks straight on average. These episodes last 3 months, so 12 weeks. They can last longer. I'm just saying like have to average on the board here. The 8 symptoms that you get, part of me wonders if it's worth going through them all while I'm here. I guess I will. But I wouldn't worry so much about knowing all of these. Get the gist of depression and you should be fine. So, but depression tends to come with sense of worthlessness, lethargy, changes in weight and appetite, sleep disturbance, energy loss. That's a big one. difficulty concentrating, guilt, or excessive thought of death and suicide. The common theme there is this just general disruption of normal feeling. And I guess it's true for every psychopathology, but for depression, I think that's your big takeaway. Dysthymia is our next term, or I think it's dysthymia, but it has a TH. So dysthymia. You can kind of think of this as like boneless depression. Um, it's milder in intensity and tend to be less strongly active and less like uninterruptedly active. But these episodes can last like 2 years. So basically, what is a dysthymic episode? It means you have this depressed mood and lesser anhedonia, so I guess subhedonia, for most of the day, for most days, most of the time. So you could still function. You might still have the occasional moment where you don't have this tinge of self-doubt and sadness and nothingness, but it lasts a really long time. I think a lot of people have undiagnosed dysthymia that they're concerned about. The Notre Dame special is seasonal affective disorder, fittingly named SAD. This is a mood disorder caused by inadequate exposure to natural sunlight. Basically, what's happening here, we talked a lot about circadian rhythms, right? Your body takes in cues from light levels and anything with your routine, but especially light levels for your class, and sends that information to the hypothalamus, suprachiasmatic. You didn't even talk about that in that class. But basically, the important lesson is that light levels enter the brain. You kind of take note of that. When it's winter and cloudy, like it is in a hypothetical Indiana city all the time, you get way less light. So you don't really get that natural day trigger as much as you usually do. And that disruption to your circadian rhythm leads to sadness, seasonal affective disorder. The new wave McWell stuff with the light lamps is actually pretty effective for this if it's ever something you felt. That's what my roommate says at least, but it's this is a real thing. This is one of those things where it's like, you just have a case of the winter blues. No, it's a real biological effect. Recovery from these disorders is pretty good. When you seek treatment for depression like this, about 9 in 10 people make a recovery, which means they can go back to feeling things again. That's great, but then about half of recoverers relapse. And that's only counting the ones that enter the system again and don't feel so overwhelmed by, oh, it's happening again. And clearly the medical system didn't work last time. Why would I trust it this time? That's 50%. It seems like there's something hard to kick there. Here we have our familiar 2-to-1 women to men ratio with depressive disorders, although this is changing a little bit more. Men are starting to come forward more, putting the whole macho thing down a little bit, which is probably for the best. Definitely for the best. But okay. So we talked about our depressive disorders. Now we have our bipolar disorders, which are still a subset of mood. If you need time to write, just let me know. I know I'm kind of rifling through information. I know it's kind of like I'm slapping you in the face, but it is how this class is taught. So anyway, the bipolar disorder, alternating periods of depression and mania. So depression is exactly what we just described, feeling empty, feeling very little. Mania is a feeling of complete, I guess the best way to say it is, the complete opposite of depression. So you have an elevated mood, way more energy than usual, racing thoughts, you're super distractible, everything that comes into your brain is a good idea. Why would I sleep? Why would I sleep when I'm happier than I would be in my wildest dreams? That's kind of the idea of mania. You see a lot of impulsive behavior because everything seems like a good idea. Everything is tinged with like an unreasonable amount of good. So commonly, people with these manic episodes spend all their money away and have unprotected sex. Those are two very common outcomes, and I think those you might not need to know those two things, but I think it illustrates what's going on very well. Everything is a good idea. Everything is bouncing off the walls happy. Our first disease is fittingly named bipolar 1. Bipolar 1 is the big dog. You have major depression, so you have all this stuff, and then the cycle comes around and you get full strength mania. So bipolar 1 is really, really nasty. You often see illusions and hallucinations at this level too. So what that should suggest to you is that there's something fundamentally wrong with the brain of a person with bipolar. This is, to put it mildly, persistent and disruptive and uncontrolled. Bipolar 2 is similar. It is, you have full-on major depression, but you have what's known as hypomania. And what that means is you might not be going and getting STDs, you might not be going and spending your entire life savings, but you definitely have symptoms of this manic episode kind of thing. So that's bipolar 2. I wouldn't expect any hallucinations on this level. Cyclothymia, which you can remember quite easily because it's a cycle. Cyclothymia is your recurring episodes of our dysthymia, right? So your most days, most of the time, depression, and then hypomania. It's kind of like a mini-me or boneless bipolar. It doesn't make it any less disruptive, right? This is a big deal. But it's certainly not as bad as a bipolar 1 patient. Again, this bipolar 1, the really bad stuff is like bipolar 1, or also what's known as rapid cycling bipolar disorder. What that means is you go through the cycles rapidly. Go figure. Tends to be associated with the bipolar 1 symptom line. Again, women tend to be diagnosed with this much more than men, for whatever reason you'd like. This rapid cycling form in particular. This rapid cycling form, again, you can think of it as like full strength bipolar, usually bipolar 1. It really doesn't respond to treatment. Your life is just endless nothing and everything. To me, there's something fundamentally disquieting that this can happen. I mean, that is a life prisoned and caged, in my view. No matter how hard you try a treatment, what lithium drugs you put in your system, it doesn't really work. That, to me, that's shocking. So mood disorders have a similar, slightly higher heritability rate to anxiety disorders. So maybe 40% of kids of people who have it will get a mood disorder. Again, you also see that diathesis stress model where a certain stressful event in life, such as a major change, a breakup, can trigger a latent diathesis, latent genetic predisposition. But there are definitely some cognitive, behavioral, psychological risk factors here too. Kind of like with generalized anxiety, what is your default? Is your default to consider things as threatening and overwhelming? If you do, that's definitely going to put you down the mood disorder path, just like it did the anxiety disorder path. Do you tend to view failure as what's known as an internal and stable attribution? Internal and stable. So internal, right? Remember our fundamental attribution error. It's kind of the opposite. You're thinking, I got a bad grade in this test because I am stupid. Not because I didn't study as much as I could have, and that's something I can improve on, because I am stupid and terrible. And the stable part means that these attributions are largely unchanged. And I will always be stupid and terrible. Again, if that's your default, that probably puts you down the mood disorder pathway. A third common theme that we see is people who consistently confirm the valuelessness of the self in interpersonal interactions. So, people who make self-deprecating jokes all the time might be at risk here. People who say, I know I'm garbage, which is something that might sound absurd, but something that a lot of people say. Hopefully short jokes don't fall under that, but we'll see. Maybe there's hope yet. But those would be your cognitive behavioral causal components of mood disorders. Okay, we talked about the large family component. Usually these things run the family. If not everyone gets them, then somebody who has a mood disorder almost guaranteed has somebody else in the family with a mood disorder. Your affected neurotransmitters are dopamine and serotonin, go figure. Those two put in overtime, keeping your brain normal. That doesn't mean that's the cause of depression, but it's an effect that we notice is that there's reduced dopamine and serotonin levels. We tend to see that the mood disorders ravage the right hemisphere more than the left, which you might remember from all the way back. That's the more integrative, holistic part of the brain um, that is trying to make sense of everything that's going on at once rather than being really good at processing one thing. Like the left hemisphere, really good at processing language, really good at processing math, but it can't really link these things, synthesize these things together. Right hemisphere that does that tends to get bodied, and you can imagine how that would impair a person. They don't see the point in everything. There's no connection. Things are disconnected. It's scary. Um, Circadian rhythms are affected by mood disorders. Well, obviously with seasonal affective disorder they are. This is true for everyone. So one of the symptoms of depression is disruption in sleep. You notice the same thing in manic episodes. You don't really have a functioning circadian rhythm. Well, it turns out that we depend on those a lot more than we first thought. Talking about bipolar disorder in particular, bipolar disorder in particular tends to have a higher heritability rate than the average for mood disorders. I guess what I'm trying to get across with all this is that bipolar is something, even though it has depression, it's fundamentally different and I think much more disquieting. Um, so it's more heritable. And unlike with depression, we don't have an easy like SSRI, selective serotonin reuptake inhibitor kind of treatment. We don't really have a particular neurotransmitter or biochemical pinned down as like a manifestation of bipolar. A treatment that we use is what's known as lithium, which is the third element on the periodic table. Lithium is a common treatment that's really high maintenance. If you get lithium supplements, you need to get constant blood work done, like once a month, to make sure that you're in the right ranges. We don't really know how it works, but we know that it works. Ish. Again, like if you're rapid cycling, you can take all the lithium you want. It's probably not going to help. Bipolar disorder tends to have the social stressor, go figure, of a stressful change or impact in life. Finally, our last thing is that bipolar disorder, you remember our trait theory, we find that people with bipolar tend to be much more neurotic and much more conscientious than average. So the C and the N in the ocean, um, it tends to be much more common in people with both of those, or to a lesser extent, one of those. So it's almost like you lost the trait lottery if you don't get lucky. But all right. We'll pick up I think we'll meet next Thursday. I'll send out an email. I'll try to give you reasonable notice, but LOL, that probably won't happen. Yep. Defeating the value of the self in interpersonal interactions. There you go. But basically, next time we'll start with personality disorders, which are slightly different than these. And I think with that plus the review session, we should be able to get through everything. If not, I'll post a video for you. Does one of you happen to know off the top of your head when your final is? I don't know. I should know, but I don't. I want to make sure I get that video up before.
Wednesday.
Yeah, I think it's the Wednesday.
It's the Wednesday? Okay. So our review session is on that Sunday the 2nd. I'll do my best to get a video out if necessary on like Monday, so it's not totally last minute. But that's it from me. I'll stick around for questions if anyone has any, but it seems like y'all are good. So good luck with everything, and yeah, we have less than a week left of school. So kind of weird.
Thank you.
Thank you.
Thank you.